want to welcome you all to today's session. But first, I want to acknowledge the land that I find myself on today. Given that we're all online, we are all in unique locations with unique stories and histories. But myself, I'm in Montreal, which is the traditional and unceded territory of the Canadian-HSO, a place which has long served as a site of meeting and exchange among nations. So I have to also tell you about some changes that are happening to this program. Until now, the program has been called CHEP, which is the Community Health Education Program. However, our funder, Health Canada, has changed their priorities a little bit. And now we have to change the program away from health education presentations towards supporting English-speaking seniors in Quebec to age in place. Or to age in the community, you know, in the way that you choose for as long as you want. So instead of health education presentations, we're going to be doing information sessions that focus on services, resources, and tools available in the community that can support you in aging in your own home, but aging in the community, whatever that means for you. You know, maybe you might want to move into a smaller apartment, you might move in with some friends or some family. All of that is aging in place, right? So aging in the right place at the right time. So my name is Erica Botner. I'm the program manager for seniors and for the SHARP program. I'll be your facilitator for today's session. We're delighted also to have Jennifer Hobbs with us here today, who I will introduce to you more formally in just a minute. Her presentation is titled, "If You Love Them, Leave Them Lists, Tips for Advanced Care Planning." It's not always an easy topic to discuss, but it's a very important one. It's about doing what you can do to ensure that your healthcare treatment is consistent with your wishes and preferences should you be unable to make your own decisions or speak for yourself. It's also about planning for the what ifs that might occur across the entire lifespan. So today you'll learn about some of the resources that are available for you for creating your own advanced care plan. I'm going to introduce you to Jennifer Hobbs-Robert. She was the Director of Nursing, Quality and Risk Management at the Jeffrey Hale St. Bridget's Hospital in Quebec City. She was also the lead for the accreditation process for the St. Bridget's Hospital, and she's been a surveyor for Accreditation Canada, both nationally and internationally since 2011. She's held a variety of positions in geriatrics, community health, nursing, health education, emergency care, as well as in occupational health. She's also worked with the Canadian Heart and Stroke Foundation as a master instructor in CPR. Currently, she's the senior advisor for the community health promotion programs for Jeffrey Hale Community Partners in Quebec City. And she's received a couple of awards in the last 8 or so years for excellence in nursing and leadership, as well as for exemplary volunteer contributions of individuals from the English-speaking community in the Greater Quebec and Chaudière-Appalaches regions. So, Jennifer, I'll hand it over.
Good morning.
I'll hand it over to you.
Thank you, Erica. Thank you. Well, good morning, everybody. And I'm very honored to be with you this morning to talk about this slightly challenging topic, but I am really hoping that at the end of the discussion and at the end of the presentation that you will have a little bit more confidence in approaching this difficult and challenging topic. And so I really do hope that the information I've included in the presentation is going to be helpful for you. So we're going to get right to it. And I want to welcome you all to the topic of love is in the details. And this presentation came about in a rather interesting way. But before I get into that, I just want to share that no one wants to really think about mortality, but unfortunately it comes to us all. Sorting out our wishes in the event of incapacity or death will be a lot easier if your representatives have the information that is necessary for them to help you. Now, when you think about it, we plan for many things such as marriage, houses, vacations, children, our retirement, just about everything except getting old. We cannot plan for every eventuality, but we can set guidelines for our wishes. We can record the information our designated representatives will need to act in our stead. This presentation has been inspired by my personal experiences accompanying patients as well as loved ones as a mandatory and an executor, but more specifically for this presentation by my readings of two fascinating publications. The first one, The Conversation Project, which I found on a website, which you have in your references by the same title. And secondly, in the reading of an excellent publication entitled If You Love Them, Leave Them Lists by our Canadian author, Catherine Rahal. In this presentation, we will review some important parts of putting together a legacy notebook for your family and your loved ones to follow in the event that you are no longer able to care for yourself or have left the living behind. If you are a caregiver, we're going to discuss the importance of having that difficult conversation with your loved one to find out what matters to them at end of life. In this presentation, we're going to think really earnestly about 1, what matters to you at the end of life? 2, having the difficult conversation. 3, I will review a prototype of a legacy notebook that you could inspire from. 4, we're going to talk about what do levels of care in the health system mean. 5, we're going to review MAID, Medical Assistance in Dying, which is taking quite a bit of place in our health system at end of life right now. And then 6, we'll review the slide with all of the references that you can use to be inspired to do additional readings and additional learning. First, what matters to you? We can't plan for everything, as I mentioned, but we can talk about what is important in our life, in our healthcare, with those that matter the most. So, how do we start the process of planning for the later stages of our life? Well, step 1, you sit with a coffee, a tea, and you think long and hard about what does a good day to you mean? What or who supports you during your most difficult times? Who in your life are your biggest supports? Try finishing this sentence when you're reflecting. What will matter to me through the end of my life is, and you complete that sentence. And then that should be the what matters to me statement. Reflecting on what matters to you with regards to end of life is not an easy reflection. And studies have shown that over 50% of individuals at the end of life have not discussed their opinions, values, or wishes regarding the end of their life. And if we reflect on the poll that Shannon put up this morning, we had about 50% of the people participating today. So the statistics confer with what our research has shown. This slide that you see, although it is dated, lists some of the issues that have not changed over time, that could be covered while speaking with your loved one about their feelings and values at end of life. Let's take a peek. In the first section, you see the values history. Is there a living will written? Do you have a power of attorney? Have you talked about organ donation? How about regarding specific medical procedures? Do you want your organs donated? How do you feel if ever you were forced to have, or not forced, but asked saying that you would need kidney dialysis? What are your thoughts on saying yes to cardiopulmonary resuscitation? How do you feel about being put on a respirator? How do you feel about nurses and auxiliary health staff artificially feeding you, artificially hydrating you? And in the second section, it's interesting and very important that you reflect, you take time alone to reflect on your overall attitudes towards your health, the perception of the role of your clinician and other health givers. How independent and how much control do you want to have at the end of life? Or do you want to turn it over to your family? How strong are your personal relationships with your family and your friends? What is your overall attitude towards life in general? Your attitude towards being sick, dying, and at the end of life? Will your religious beliefs and backgrounds have an impact on how you want to end your life? How do you see the living environment? Would you prefer to end your life at home or in a hospice or in a hospital? How are your finances doing? And have you thought about funeral and all of those kinds of things that need to be organized at the end of life? And we're going to get into that in great detail in a little bit. Okay, so now we're going to talk about planning your talk. Having a say in your health care is more likely if you share how you feel about certain situations that could arise now and in the future and towards the end of life. It is amazing how a simple conversation at supper time with your loved ones or over a cup of tea and a muffin, and you talk about little things, not all at the same time, but over time, if you take a walk with a friend and you say, you know what, Janice, it's really, really important that I don't have any extended equipment at the end of my life. How do you feel about it? And you just have a general, easy flowing conversation so that if you do these things ahead of time, it is not so intense and so stressful for your family at the end. The conversation should be part of life, easy and an easy flow with circumstances that are easy as a cup of tea and sharing a meal. So now, the first thing that I really came across was a document called Having the Conversation. And here's the website, and you also have it in your references. And it's really how to get started on that difficult conversation. They have leading questions, they have topic tips on how to discuss different things, and really how to talk about what matters to you and eventually have a say in your healthcare. Because if you don't talk about these things, no one will know. Because very often the healthcare professionals do not have time to get to your written documents at the end of life. So if your family and your friends already know your values and the way that you want to end at the end of life, it's going to be very, very helpful. So this workbook that I'm referring to, that you have the references at the end, is really a tool to help you be independent and autonomous in deciding what matters to you. It's an 8-page workbook, and it's not really about making specific medical decisions. It's about thinking and reflecting on what matters to you and sharing your goals and preferences with your healthcare team, and equally as importantly, your loved ones. Then together you can choose the kind of care that is right for you. Do this exercise. Do the workbook by yourself or with someone else. Choose the way to complete the workbook that works best for you, and take your time. You do not have to complete this 8-page workbook all in one sitting. It's okay to skip the questions if you're not into it on that day, and come back to it when you're feeling stronger, or you've just got a little bit more energy, or maybe when the sun is shining, not like today. Share the workbook. Keep it out on a counter or in a drawer. Tell people where it is. Share this information. Bring the filled-in workbook to your next appointment so you can talk over your answers and questions with your physician. Even if they don't think that they have the time, make them take the time. That's why they get paid the money they get paid. Be forceful. It's important. Be prepared. Even if you don't have an appointment with your doctor soon, or you won't be seeing a family member, maybe they live outside of town, doing the workbook by yourself will help you to be clear about your wishes instead of the healthcare team making those decisions based on what they think you want. This If you're a caregiver and you're helping someone complete the workbook, here are some things that you may want to keep in mind. Explain to them why you think this might help them. You may say, I just want to make sure we know what's most important to you so that we can have a more useful conversation with our healthcare team. And do it in small, digestible bites. It's always okay to skip over questions, as I mentioned before. You can even let the person pick the questions that appeal to them on a day. And if they get tired or overwhelmed, take a break, come back to it later. And if the person that you are helping is prone to confusion, keep the number of helpers small. Having many people present can increase pressure on the seriously ill person or those that suffer a little bit from dementia. Having 1 or 2 people at most assist in completing the workbook and then share it with the others. But please take the time to have that conversation. This is a sample page in the workbook. For example, how would you respond to each of the following statements on this slide? And then what you do is you kind of make the place on the line that is closest to the way you think or believe about the statement. There are no right or wrong choices. Your answer is about what works for you. Doing this will help. And it's really going to help your priorities become clearer. As an example, as a patient, I'd like to know, just give me the basics, nothing more. I want to know, or at the other end of the spectrum, I want to know every single thing about me. Secondly, when there's a medical decision to be made, I would like my healthcare team to do what they think is best. I don't want to be involved. It stresses me out too much. I can't cope. Or it's my decision and I want to be the one to make it. So these are the types of questions that you're going to see in this workbook that will help you to reflect if you have not already done this. We're going to talk a little bit about advanced care planning. The references that I used, because things are different in every province and in every country. So I really did specifically use the references and guidelines specific to the province of Quebec. And with regards to legalities, I do use this site, M.ScA, which is an excellent site. It's in your references, and I would strongly encourage you to get on that site. It is perfectly bilingual, easy to navigate, and you will find every answer to your question there. And there is even a little type area where you can ask additional questions. So in this section, Advanced Care Planning, we're going to review some of the key elements regarding this topic. Now, many of you, this may be a review, but I thought it might be important to include it in the presentation. In the last decade, there's been a growing support for planning in advance for decisions that you may have to make at the end of life. You may choose to do this planning formally by means of advanced directives, or simply informally through discussions with family members, friends, and healthcare and social service providers, or a combination of both methods. And what that means informally is when you're having that cup of tea and you say, you know what, I just read a study saying that, if you have cardiopulmonary resuscitation after the age of 75, that the results are not very successful, and that you do not leave the hospital with a neurologically intact brain. So knowing that, I don't think at the end of life, if I have a cardiac arrest, that I want CPR. So these will stay in the brain of your friends. They will stay in the brain of your daughter, son, husband, whatever. So that when the doctor says, did your wife, mother, sister ever express how she feels about having cardiopulmonary resuscitation, you'll be able to answer and say, she did not want it. She did not want it. No problem. That's what we're going to do. Okay? So it can be formally in the way of a written directive or informally through conversations that you have as you age with your family, and you're going to be documenting this in this beautiful book that I'm going to describe very shortly. So basically, from the M.ScA site, advanced directives let you put in writing your wishes about certain types of medical care in certain situations, not all, but certain situations. You can say whether you want or don't want a specific type of care. And these directives will only be used if you cannot make your own decisions about this type of care. When do we use advanced medical directives? Well, each time a treatment is proposed or suggested, excuse me, doctors must check that you understand some basic things: your condition, the treatment that they are proposing to you, risks and benefits of the treatment, and what could happen if you refuse treatment. That is what the Code of Ethics of a physician include. They need to explain the treatment, the risks involved in the treatment, and what will happen if you refuse the treatment. So this is their duty. They're law bound by that. Advanced directives will only be used if the doctor decides that you don't understand the things that he is proposing to you and cannot make your own decisions. If you cannot make your own decisions, the doctor must check if you have written directives somewhere and what they say. Very important. If you are going to write down in a formal document your medical directives, you need to do so while you have all of your mental capacities. Discussions with family members are an important part of the advanced care planning process. An important reason for the whole process is to relieve your loved ones from the burden of making these very hard decisions, or of watching you go through the unnecessarily long process of dying without knowing how you wanted to end your life. So these conversations are essential. Advanced medical directives only apply when you cannot make your own decisions known at that time. There are 5 treatments that you can or cannot accept with regards to advanced medical directives, and they are: 1, cardiopulmonary resuscitation. If you do not know what that is, it's basically a maneuver to restart your heart and breathing, such as mouth to mouth. 2, being put on a ventilator-assisted breathing or breathing device if you cannot breathe on your own, or a respirator. 3, the option of being started on kidney dialysis, which is a machine to clean your blood if your kidneys cannot do it anymore on their own. 4, forced or artificial feeding. Forced means against your will. Artificial means you can't eat on your own. And 5, forced or artificial hydration. So IV solutions through a vein into your body if you are no longer able to answer for yourself. Those are the 5 treatments that you can agree to or disagree, and you can include in your medical directives. Advanced medical directives do not let you demand a particular health care treatment. For example, you can't demand dialysis before being diagnosed. The medical staff will judge which treatment is appropriate for you in that case. So to summarize, you can have discussions with family, friends, or loved ones about these issues, or you can write it up in an official document. A living will is a written document with your wishes regarding medical care. A living will only be used if you can't make your own decisions or express yourself. It helps to guide people who might have to make decisions for you. In Quebec, there's no law specifically on living wills. However, they do have legal value because Quebec law says people have the right to agree or refuse medical care. Also, the law says that the people who can agree to care on your behalf must consider any wishes you expressed in the past. So that Sunday supper conversation on kidney dialysis, where you said, I never want to have that, your loved ones or caregivers are legally bound to respect that. We're in the third section now, and we're starting to get into what we call the legacy notebook. And the remainder of the presentation will focus on getting organized in terms of our things, whether they be financial, symbolic mementos, our important papers, username, passwords for computer programs, computer subscriptions, and all our other stuff. And the objective or the goal of leaving this roadmap or legacy notebook is to serve as a guide again for your loved ones, your mandatory or your executor when you pass away. And this legacy notebook was inspired by a book I recently read in reading and researching for the presentation. And it is by the Canadian author, and she resides in Montreal, and her name is Catherine Rahal. And when I read this book, I really did think that the information contained in it was easy to read and I was hoping that it is immensely helpful to you. I really am, because it was immensely helpful for me. I was able and very fortunate to be able to chat with the author, Catherine, and was given permission to copy excerpts of her book on this presentation in the following slides to give you an idea of the contents of this tool. So let's take a peek. Here is the cover page. And I never recommend things when I give presentations, but I am going to recommend this. It's extremely well designed. It's literacy friendly, easy to navigate, and I really do think it'll be helpful for you. It flows, and your family will be able to follow in a sequential fashion everything that you've written in. The first section is everything regarding people. You may think that your family and loved ones know everything about you, but that is not always the case. The people section should contain contact information for all those individuals who play a part in your life. And look at the different sections just quickly. There's lists for you to put all of your information, your social security number, Medicare, all the other different kind of passports, because eventually your loved one are going to have to cancel all of this stuff. Things on caregivers, your personal delegates, for example, your executor, the power of attorney, your mandatory, emergency contact numbers. Do you have a financial advisor? Which is your bank branch contact? Do you have a notary? Do you have an accountant who takes care of your income tax? And it puts down in the way their email, their phone number, all of those different things. Are you affiliated with the church? Are they going to have to be advised? And your children, of course, and all of those different things. So the people section is quite comprehensive. In the people section, you'll see how it is designed. For example, the first section, all of the information on you, your family and friends, your email, cell phone number, just the way that she writes it is very clear. And there are 10 pages dedicated to people. So you can imagine, all different categorized. The next section touches on paper. Everything related to your estate, your care documents, your legal documents, civil documents, your financial records. The author in her discourse mentions that we have much more paper in our lives than we know what to do with. And when we go, we leave it all behind for someone else to sort through and handle. No fun. For those of you that know what I'm talking about, it is no fun. The most important documents for your representatives include the yellow highlighted section where you see the circle. But having the additional documents on this page easily available will be immensely helpful to your loved ones, all in one section. So the paper section of the Legacy Notebook is very important. And here is an example of how those things are divided. your driver's license, your social insurance card, if you're a United States citizen, if you have any other nationalities, your passport. Do you have a Nexus travel card? Your proxy, your wills, codiciles, do not resuscitate signed forms, etc. She's thought of everything. She really has. The book was written 2 years ago. The next section touches on money, assets, and debts. We all know and understand the very great importance of having our finances in order at the end of life. And if we don't have a chance to do that, it really can cause havoc for the family. There's 10 pages allocated to money, assets, and debts in this book. And the chapter really does help you to organize all things financial. And this is what it looks like. So there's a lot of different sections: your bank accounts, your cards, insurance policies, retirement plans, your investments, business interests if you had a business, all of your income, your debts, all your different major credit cards, other types of cards that you're going to have to cancel. Here's an example here: account number, contact number, branch for the bank, your working income, automatic deposits for your old age pension, all of those different types of things. And she puts them down in a way that will be easy for your family to follow. In this era of digital footprint, it's amazing how many usernames and passwords we have to keep track of. And this is the section that talks about this. You may not think that you have much of a digital footprint, but you would be surprised when you sit down and try to list all your usernames and passwords. And as technology advances, we need to be even more vigilant in keeping track of all of our passwords. This chapter provided some very, very helpful tools and information on how to proceed, and there are 5 pages of it. Email addresses, iCloud storage, online subscriptions, how to list them, how to cancel it. Do you have different computers, an iPad, an iPhone, your computer? What are the usernames, the passwords, etc.? Are you on Etsy? Are you on Marketplace? All of those things. The next section talks about stuff and legacy items. The author of the book stresses upon the importance of distinguishing between monetary market value and emotional value of your things. The author offers important and helpful information on how to prioritize and when. 4 pages devoted to this section deals with personal goods of no monetary value and how and where to dispose of them, and what to do with the stuff the kids and friends want to have, and what to do with all the rest. Essentially, Catherine states that for the majority of our stuff, there are 3 essential choices: repurposing, donating, or disposal. Not everything will require your input, but we should mention those things that are important to you. The rest will be dealt, though it may not be in a way, or it may be in a way that is different from what you would like it to have been done. And the last section deals with final wishes, and this is a very important section. It's the part that we really don't want to think about too much. And when the instructions in this section are followed, that means that we are no longer here. Let's look at the categories covered in this short 2-page section. 1, your personal wishes: burial, cremation, memorial service or not, memorial celebration, a reception afterwards or not. And 2, have you made the arrangements? And more importantly, have you already paid for them? And keep those receipts handy because your family are going to need them. Our final wishes are as individual as we are, but we need to provide the written details to our representatives. Consider carefully what's truly important to you and share this information. And this is what it looks like. Donations to science, what kind of arrangements do you want? Have you prepaid them? All of that. Okay, so now we're moving into the section that we call goals of care. These are usually presented to you when you are in the hospital or to your family, if you are in a long-term care facility upon admission. And I want to review briefly what these are. Goals of care, or life goals, is a discussion that is intended to facilitate communication when determining what care and treatment a seriously ill person does or does not want to receive. And at the end of the discussion, which is usually done only by a physician in Quebec, nurse practitioners do it elsewhere, between the physician and the patient, 4 options are to be considered. Level A is where, if you are in a long-term care or you're in a hospital, you want your life to be prolonged by any means necessary. And that means that the healthcare team will pull out all the stops, put you on all the bells and whistles, respirator, kidney dialysis, artificial nutrition, artificial hydration, you'll have feeding tubes. They will do everything that they can to keep you alive. And that is when you would check, yes, that's what I want at the end of my life. I want all the bells and whistles. They will tick off the box called level A. Level B, prolonging life with limited care. And basically what that means, it's they will do interventions that will correct deteriorating health status while maintaining the person's quality of life. What that means is that you would have surgery. Let's say you develop some sort of a surgical issue, a bowel obstruction or whatnot. A level B would mean that you would be either transferred to the hospital, or within the hospital you would be operated on, and you would have the tubes and all that kind of thing. And but you may not get every single thing. They would come back and ask you, do you want more surgery? Level C is ensuring comfort as a priority, which is different. This is where we're changing from prolonging life to ensuring comfort. And it's the first of 2 comfort levels. Example, if you develop a cellulitis and you're in long-term care, if you fall and you break your hip, they will ensure your comfort for the cellulitis by starting you on antibiotics. If you get a pneumonia, they will put you on antibiotics, maybe 1 or twice, 3 times. If you become severely dehydrated, they may start an IV, but more for comfort and relieving symptoms. But they'll stop at a certain level. That's level C, and you make those choices. And the last level is simply ensuring comfort without aiming to prolong life, which would be, for example, if you're in a long-term care facility and you develop a pneumonia, what they will do is they will ensure comfort through mouth care, through pain medication, through medication that might alleviate some of the secretions that you have, etc. And the doctor will explain these levels on a regular basis. They have an obligation to revisit your choices every few months if you are in long-term care, and in the hospital even more often, depending on the status of your condition. So a lot of people do not know about these goals of care or levels of care. You can get more information on websites. I've cited some references at the end, but it is important for you to be articulate so that you can make an informed decision when you are presented by the physician for these levels of care, either for yourself or for your loved ones. Now we're starting to move into true end of life. And medical assistance in dying is something that has been around for a while now, but it is really starting to become more prevalent. And I do a lot of visits through accreditation, and I'm seeing one of the things I do evaluate is how medical assistance in dying is followed up on in hospitals and in long-term care. And what I've noticed in the last 5 years is that more and more people are requesting for MAID. Now, let's review. In Quebec, people who are suffering greatly, and it does not have to be just physical pain, it can be the total pain experience, which is a combination of psychological, social, religious, and physical pain. And that's an important notion to remember. But people who are suffering greatly can ask a doctor to give them medication to end their lives. This is called medical assistance or medical aid in dying. Provincial and territorial governments have the responsibility for determining how and where healthcare services are provided, and they make policies with regards to medical assistance in dying. So if you look at the history, in 2016, the Parliament of Canada passed federal legislation that allows eligible, big key word, eligible Canadian adults to request medical assistance in dying. In December 15th, 2022, last year, the statement by Ministers Lametti, Duclos, and Bennett on MAID, they revised it, and it came into force on 2021. Now the new law includes changes to eligibility, who is eligible, different procedural safeguards, and the framework for the federal government's data collection and reporting regime, which is extremely strict. Now, let's just take a little bit of time, just a couple of minutes, to review what is meant by a serious and incurable illness, because those are the people that are eligible for MAID. First of all, you must be 18-year-old and, for now, 18 years old and older. You must have a Quebec health insurance card. You must have the mental capacity to make your own decisions about your medical care. You must have a serious and incurable illness. You must have a medical condition that seriously affects your health with no chances of getting better. You must be in constant and unbearable physical or psychological pain that cannot be relieved in a way that the patient feels is tolerable. And that is the key point, in the way that the patient feels is tolerable, not the doctor. Oh, I've given you enough medication, you should be feeling pain relief by now. No, it's all about your pain sensation. And you must make a voluntary request for MAID that is not the result of outside pressure or influence. I will let you all read between the lines on that one. So, with that being said, what are the steps for medical assistance in dying? Well, once the request comes from the patient, these are the steps that are followed. You must tell the doctor about your decision that you want made orally. You ask the healthcare professional for the government form and you fill it out. You sign and date the form in front of a healthcare professional. And the form must also be signed by this professional and 2 independent witnesses. This means the witnesses will not benefit in any way from the person's death, for example, by inheritance, and are not part of the person's medical team. Step 4, you must repeat the wish to receive medical aid in dying at each new meeting with the doctor or other healthcare professional. Step number 5, those who ask for medical assistance in dying can change their mind at any time right up until the last minute. They can also ask for a postponement. And step 6, there must be at least 10 days between the time the request is made and the time medical assistance in dying is given. And in some situations, and I have seen these situations, this period can be shortened. What is the procedure? What happens? In Quebec, the doctor personally gives the medication that causes the patient's end of life. Not a nurse, the doctor. Many of the drugs that are commonly used for this procedure are already marketed in Canada and are prescribed at lower dosage for common purposes, such as for nausea, pain control, and anesthesia. The doctor must stay with the patient throughout the process until the patient passes away. The patient's loved ones can be there, along with any other people the patient wants present. It's important to remember that doctors cannot be forced to give medical assistance in dying. For example, they can refuse it if it's against their personal beliefs. In these situations, the institution must find a new doctor who will agree to look at the patient's request. After the person dies, the doctor must send in some forms, and that's the data collection piece I was referring to earlier. And the form has to be sent to La Commission sur les soins de fin de vie, the Commission on End-of-Life Care, within 10 days after the death. One of the duties of this organization is to make sure that the medical aid in dying followed all the rules. They're all audited. A form to the Collège des Médecins du Québec, the Association of Doctors, Medical Doctors of Quebec, or to the healthcare institution where the person received medical assistance in dying is sent. So there are some strict guidelines that are followed. So everyone, as we started this discussion an hour ago, we knew that it was going to be a little bit of a heavy one, but I really, really do hope that some of the information that you have heard about in the discussion has assisted you and will spur you forward to getting your legacy going, whether it's through the purchase of this book, whether it's just doing it in your own way in a binder or in a notebook from the dollar store with little sections, that is up to you. But please, for your sake, for your family's sake, it's an excellent exercise to alleviate stress, challenges at the end of life for your family and loved ones. If you really do feel like you are alone and you do not have a family or friends close by, you can journal, you can write things down, and you can share this with your doctor. You can also keep this journal handy and bring it with you when you go to the doctor or if you have to go into the hospital or whatever. And this journal will share some of your feelings and some of your wishes. Online, on the M.ScA site, there are the official documents, mandatory, power of attorney, banking mandates. All of those things are there. You don't have to spend a lot of money. Sometimes you will have to get things homologated by a notary, but there's ways that you can write down things. I do not want CPR. I do not want kidney dialysis. I do not want respirators. I want to be comfortable at end of life. So these simple things that you can write down will be respected if somebody knows about it. And if I can just leave you with one thing is don't worry. Don't worry at all about those things. Try to get things down on a little journal. Choose the prettiest journal you can get. They've got some gorgeous ones. I'll give you an example here. Where did I just put it? Look at this at the dollar store. You know, there's some beautiful ones, and you just write down in a little page, and you get the dollar store little things that you can separate. You don't have to go expensive, and you just put down what you want, and you bring it with you. And if you don't have time to do that, that's okay too, because when you're in the hospital, you're going to befriend nurses, you're going to be befriending personal care attendants, your doctors. You won't be alone. Here are the references that I used to develop this presentation, and you can refer to them. You can click directly on the links and get more information. And I thank you so much for your attention, everybody.